I thank you for your testimony, and we will now move to questioning. I will begin and recognize myself for 5 minutes. Dr. Lynch, to better understand what occurred with the index case and how a DCD, or donation after cardiac or circulatory death, how a case like that works, is it fair to say that it is not a failure in a DCD case if the patient doesn't end up dying in the allotted time and the process is during the procuring of the organs, if it is stopped?
It's fair to say that the OPO has a duty to look for donors. The prognosis, meaning planning whether or not an individual will expire within a time period that would allow for the recovery of their organs, is imprecise. So in good faith cases, there will be instances where a patient has a withdrawal of care, is allowed to progress to a natural death, but that occurs over too long of a timeline to make the organs usable.
And you wouldn't consider that a failure, would you?
I would not.
However, it is a failure if at any point in the process leading up to the removal of the patient from life support and declaring that patient is deceased, that the patient shows signs of improvement, neurologic function, such as signs of pain or fear, if you see a patient crying, if you see these kind of neurologic responses, the process should be immediately stopped. Do you agree?
I agree.
Or in another case, when a patient was awake and following commands, yet the OPO did not terminate the organ procurement process at the moment the patient exhibited that behavior. Is this how a DCD case should work?
No, it is not.
Why is that?
So in DCD, the appropriate initial and then the subsequent evaluation is key. Identifying those individuals where the injury to the brain is sufficient that they will not recover and allowing them to progress to a natural death. If over the course of the days between the OPO's initial assessment and when they ultimately go to the operating room, if they're improving, then it is unlikely that they're going to pass in that time frame and they're being exposed unnecessarily to harm.
So continued reevaluation as the process continues has to be part of the process, correct?
Correct.
We have seen continued reports of these concerning instances, and an instance at times by both OPOs and the OPTN board and its investigative arm that these cases do not represent a failure in the system. Based on your opinion as a transplant surgeon and now in your role of as the chief of organ transplant branch of HRSA, can DCD continue to be done in a way that protects patient safety and honors the sacrifice of what these patients are doing?
Absolutely. So this is critical to ensuring patients' ability to have their wishes fulfilled. So if you make that brave decision to be an organ donor and you can pass in a manner that you can be recovered safely as a DCD donor, you should be afforded that right. We're also relying on these organs to save the lives of other Americans. This is complex care. It's technically demanding, but it's knowable and fixable. This is something that can be done safely.
As part of the investigation, HRSA analyzed information from over 350 unique cases of ANR patients, or authorized not recovered. This means that the patients were considered for DCD recovery, but no organs were transplanted. The report continues that 103 of these cases, or nearly 30%, had concerning features. Could you explain what some of those features are and what the common themes are in these cases?
So HRSA's report and what we documented in our corrective action plan essentially identified 4 problems. There was the inability to perform a good initial or subsequent neurologic exam and identify those individuals who are likely to progress. There was a poor pattern of collaboration and respect for the input from the primary medical team, the hospital providers. There was poor communication and treatment of families. And then there was poor documentation of what was actually occurring with these patients in the OPO's records.
Would you say that the issues occurring in these cases are more related to policies on how the situations are handled, or personal errors, or a lack of communication from team? Because there are multiple teams that are involved as this entire process continues.
So this is, as I said, this is a technically demanding form of care. It involves good collaboration between the OPO and the hospital. But every area in the country has exactly one OPO. They are the only ones who can provide this care. It is within their scope to make those relationships, do the education for the hospital, and provide that expertise and support to help them.
I thank you for the clarity of your answers. I think it is important for this discussion. I now yield 5 minutes to the ranking member for her 5 minutes of questioning.